Today's presentation will be an introduction to intravenous armamentarium. These topics are covered in chapters 22 and 24 of the Sedation book by Malamed. The student doctors presenting today are Alexandria Cobb, Brandon Davison, Irini Mishrecki, Elizabeth Alabi, Emerald Ferguson, Eric Buras, Jared Fletcher, Jasmine Gozi, Joseph Rawlings, Kenesha Smith, Aaliyah Billings, Kelsey Kellerman, Kyle Wonkwo, Madison Bowler, Nia Riot Fields, Tiffany Brown, and Wafa Hamid.
So this is the armamentarium that you would need to start an IV.
In our field, you will find an IV administration set, drug tapes, IV bag filled with 0.9% sodium chloride, Tegaderm film, shielded IV catheters of 2 different gauges, stretch tape, alcohol swabs, 2x2 gauze, surgical tape, and a tourniquet.
So first you would get your patient, and then you would, hi patient, you're going to wipe down, first we're going to decide where we're going to start the IV. You can start in the anterior cubital fossa, the back of the hand, possibly the foot, or even the neck. So wherever you decide you're going to start the IV, you're first going to wipe down the area with an alcohol pad. You're going to make sure your IV is set up in the IV stand above the patient. Then you're going to tourniquet. Let's say we're doing the anterior cubital fossa. We're going to tourniquet it above where we're going to start the IV. And then we're going to decide what type of catheter or needle we're going to use in the gauge. So each gauge represents a different thing. So the smaller the gauge, the larger the needle.
The larger the gauge, the smaller the needle.
They decide the gauge size by how many of the needle can fit into a 1 millimeter circle. So a 22 gauge needle is bigger than a 24 gauge needle. So once we puncture the vein and you get a flash, you see a flash of blood within the catheter, you know that you hit a vein. And you want to make sure that you're inside the vein and not going through the vein. And then you're going to press on the vein to make sure there's not a blood rush. You're going to stick the IV administration kit.
Delivery of the IV infusion from the bag to the patient requires tubing. IV administration sets, or IV tubing, as they are commonly known, have several components in common. The piercing pin is the part of the IV set that is inserted into the bag of IV fluid. It is a rigid piece of plastic that must be kept sterile before its insertion into the bag of solution. Located immediately below the piercing pin is a drip chamber. The drip chamber is an enlarged, flexible, clear plastic chamber into which fluid from the bag will drip. The drip chamber has 2 functions: to prevent air from entering into the IV tube and to permit regulation of the solution's flow rate. Conversely, overfilling of the drip chamber prevents the dentist from assessing the flow rate of the IV fluid. When the typical adult IV infusion set is used, 10 drops equals 1 milliliter of solution. The drip chamber should be filled approximately halfway with IV fluid to prevent air bubbles from entering into the IV tubing. Although isolated air bubbles within the tubing are of little consequence, the naive patient might be quite disturbed to see any bubbles of air enter into his or her body. An unfilled drip chamber, or one just barely filled with solution, will allow air bubbles to enter the tubing as each drop of solution falls from the bag into the drip chamber. Extending from the drip chamber is a variable length of plastic tubing, commonly 78 inches long, to which the IV needle will be attached. Along the length of this tubing are found the rate adjustment knob, injection port or syringe port, a rubber bulb, which is not always present in all infusion sections, and an adapter for the needle or syringe. The rate adjustment knob permits regulation of the rate of flow of the IV fluid into the drip chamber. The injection port is usually a rubber diaphragm that fits over a hard plastic spur off the main IV tubing. Because of potential dangerous needle stick injury, infusion sets are available in which the syringe connects to the injection port through a Luer lock connection, so-called a needleless solution.
And then at that moment you started your IV. And when you're done with the IV, you're going to put this Tegaderm film over top where the IV was to ensure that it doesn't move and that there's no allergic reaction, say if you were to use the surgical tape. And then when you're done, you're going to use this gauze. The end.
Intravenous drug administration is a method of administering concentrated medications, diluted or undiluted, directly into the vein. There are various methods to do intravenous drug administration. Method 1 includes a needle being maintained in the vein without a continuous infusion. This means that the access to the vein is maintained during the procedure with periodical flushing of the needle with 1 millimeter of solution to keep the vein patent. Method 2 is the direct IV administration. This means that there is no access to the vein being maintained during the procedure. Method number 3 is continuous IV infusion, which means that the access to the vein is maintained during the procedure as a slow flow of infusion, usually by a solution bag. Needle maintained in vein without a continuous infusion. Step 1 is to place a tourniquet on the patient's right or left arm, engorging the veins. Next, you will prepare the injection site using a surgical scrub, i.e. 60 to 7% alcohol-based solutions on a single-use swab or cotton wool ball. You will then place a wing infusion set or a hollow metal needle of a syringe containing the drug into the lumen of the vein. Remember to aspirate once the needle tip is ensured to be in the lumen of the vein. After the tourniquet is then removed, a syringe without the needle attached is connected to the needle that will be left in the vein and is taped into place. After the drug is titrated to effect, the syringe is detached from the needle. A second syringe is then attached to the needle containing a solution of sterile water. Following drug administration, there will be periodic flushing of the needle. Direct IV administration. You will first place a tourniquet on a patient's right or left arm, engorging the veins. You will then prepare the injection site using a surgical scrub, i.e. 60 to 70% alcohol-based solution on a single-use swab or cotton wool ball. You will then place a needle of the syringe containing the drug into the lumen of the vein. Remember to aspirate once the needle tip is ensured to be in the lumen of the vein. You will then remove the tourniquet and slowly administer the drug into the vein. Following drug administration, you will remove the needle from the vein and apply pressure to the site to stop any bleeding.
Continuous IV infusion. Continuous IV infusion is the most highly recommended technique in all situations in which a patent vein is to be maintained for a period of time exceeding but a few minutes. In this technique, patency of the needle and vein are maintained by the constant infusion of IV solution from the bag into the needle and the patient's vein. The only drawback to this procedure is the possibility that, number 1, the infused site might become contaminated. This is an extremely unlikely occurrence. And also, number 2, the drip rate might be too rapid, causing the bag of solution to be emptied during the procedure. Re-administration of sedative or administration of emergency drug is easily carried out by simply inserting the syringe needle into the injection site on the IV tubing. The ease of maintaining a patent vein and the increased safety afforded the patient by the continuous IV infusion are the primary reasons for considering this technique as ideal for IV drug administration. Continuous IV infusion steps. Place a tourniquet on the patient's right or left arm, engorging the vein. Prepare the injection site using a surgical scrub, 60 to 70% alcohol-based solution isopropyl alcohol or ethanol, on a single-use swab or cotton wool ball. Place the needle of a syringe containing the drug into the lumen of the vein. Aspirate once the needle tip is ensured to be in the lumen of the vein. Following removal of the tourniquet, the flow of IV solution is started, and the needle or catheter is secured. The IV drugs are administered through an injection port on the tubing, and the drug syringe is then removed. Adjust the rate of the IV to maintain a slow flow that will prevent needle occlusion during dental procedure. Start the dental procedure.
Advantages and disadvantages of various methods of IV drug administration.
Direct IV drug administration. Some of the advantages include that this method of drug administration is good for emergency situations in which there's a lack of time or equipment, but there is a need for an IV drug administration. It is ideal for situations in which the needle needs to be maintained for only a very short period of time. So this would be in the instance of having blood drawn for laboratory tests. And then the final advantage is that removal of the needle from the vein would make it difficult for accidental over administration of the drug. So this will reduce the chance of a drug overdose. Admittedly, according to Malamed, there really aren't that many advantages, and the advantages that I've mentioned aren't really significant enough to justify using this route of administration for IV drugs. And according to Malama, these are the disadvantages of using this route of administration. The first one being that in the event that more drugs need to be administered or a reversal agent is needed for the patient, venipuncture would have to be redone. A second disadvantage is the fact that if a patient's blood pressure drops significantly during the procedure, locating superficial veins would be difficult for readministration of the drugs. And then lastly, this kind of summarizes all the disadvantages and all the reasons why this route shouldn't be used, is that it seems illogical to remove the needle when during a procedure there's a high likelihood that you will need to re-administer drug or reversal agent or something to the patient. So having a patent needle would be advantageous in these situations, but if you were to go through the direct IV drug administration route and remove the needle and not have the patent vein, then having to redo it over again would just serve to further waste time for the procedure.
Needle maintained without continuous infusion. Advantages is that this technique requires that the needle remains in the vein throughout the procedure. Its patency maintained by periodic flushing with some solution. Thus, it can be used for longer procedures. The only disadvantage is that the periodic flushing of the needle is required to prevent clotting of the lumen from occurring. So, during a busy dental procedure, it is not uncommon for the dentist and the assistant to become deeply absorbed in the oral cavity and to neglect to flush the needle, in which case the lumen of the needle becomes clotted with blood and another vein must be recannulated. Continuous IV infusion. Advantages is that continuous IV infusion is the most highly recommended technique in all situations in which a patent vein is to be maintained for a period of time longer than minutes. So it is highly favorable for longer procedures. In this technique, patency of the needle and vein are maintained by the constant infusion of IV solution from the bag into the needle in the patient's vein. So, readministration of sedative or administration of emergency drugs is easily carried out by simply inserting the syringe needle into the injection site on the IV tubing. Also, the ease of maintaining a patent vein and the increased safety afforded to the patient by the continuous IV infusion are the primary reasons for considering this technique as the ideal for IV drug administration. Disadvantages is one drawback to this procedure is the possibility that the solution might become contaminated, an extremely unlikely occurrence. Also, the drip rate might be too rapid, causing the bag of solution to be emptied during the procedure, usually in longer procedures.
The vein finder.
NIR vein finder. Though not a necessity, it is highly recommended that a near-infrared NIR vein finder is included in the armamentarium for moderate IV sedation. Chow et al. Demonstrated a significantly increased rate of successful venipuncture compared with conventional venipuncture technique in obese African American and Asian subjects, though other clinical trials demonstrated no increase in cannulation success. Malamet 573. Many individuals that perform venipuncture highly recommend having a vein finder included in IV armamentarium. And to the right, you'll see pictures of the vein finder in action, as well as how many people it takes to place the IV catheter and hold the vein finder at the same time. So what is the vein finder? A vein finder can be identified by either a red, orange, or green light that is shined on the skin. This device projects light on the target vein access area. The NIR vein finder relies on hemoglobin to absorb the infrared light and display a road map of the venous structures. And to the right, what you're witnessing is a video showing the hemoglobin present in the gentleman's arm to express the veins. Disadvantages of the vein finder. 1. Projection of the light onto the skin makes it difficult to determine the depth of veins. 2. This device requires multiple individuals to both use the device and complete venipuncture. 3. The devices are expensive, approximately $15,000, and are cumbersome.
The tourniquet.
A tourniquet is used to prevent the return of venous blood from the periphery to the heart while allowing for the unimpeded flow of arterial blood into the limb, thereby engorging the veins, making them more visible and easier to cannulate. A number of items may be used as tourniquets, such as thin rubber tubing, a Velcro tourniquet, and these both are seen in this picture. Above, you see the Velcro tourniquet, and below is the rubber tubing, and also a blood pressure cuff can be used.
Needles used.
There are 3 types of IV needles: the hollow needle, the wing needle, and the indwelling catheter. The hollow needle is a traditional IV needle and represents the basic design of an intravenous needle. All others are modifications of this needle. It has a shaft of varying lengths, commonly ranging from 3/8 of an inch to 1.2 inches, with a triple valve that extends from the tip of the needle to the heel of the shaft. The hub is a large plastic or metal portion where the IV tubing or syringe can be inserted. This needle is now reserved for either emergency situations where other needle types are not readily available, or in the case of drawing blood for lab tests. The wing needle is used for moderate sedation procedures and is the device of choice for venipuncture of superficial veins due to its ease of manipulation. Common components are needle cover, adapter, and flexible wings. Other names for this type of needle are the butterfly needle, the scalp vein needle, and the winged infusion set. The indwelling catheter is mostly used in general anesthetic procedures. Several types are available, but the catheter over needle is the most commonly used of this needle. This needle is less rigid than the hollow and wing types, which prevents the perforation of the posterior wall in the mobile area, such as the antecubital fossa or the wrist. It has also been modified to prevent needle stick injury by retraction of the needle after removal from a venipuncture site.
Gauges usually refers to the outside diameter of the needle. Needles used for venipuncture generally range from 14 gauge to approximately 24 gauge. The lower or smaller the gauge number, the larger the size of the lumen. Therefore, a 16 gauge needle has a larger lumen than a 24 gauge needle. The term gauge derives from the number of pieces of wire, in this case needles, that can be placed in a 1 millimeter circle. Therefore, only 16 needles of a 16 gauge will fit in the same space occupied by 23 needles of a 23 gauge. The most commonly used gauges for IV sedation in dentistry are going to be your 20, 21, and 23 gauge needles. Choosing the correct size needle is dependent on the patient's age, the location of the IV, and the procedure that is going to be done. The indwelling catheter.
The indwelling catheter. Indwelling venous catheters are used for administering drugs or fluids to patients parenterally by means of infusion. They are used for total intravenous anesthesia and for taking blood samples. The indwelling catheter is recommended for use within the operating room and in most general anesthetic procedures. It has also become the preferred needle for IV moderate sedation. Many types of indwelling catheters exist, including the catheter over needle unit and the catheter inside needle unit. The catheter over needle is recommended in dentistry. To the right is a picture of a catheter over needle, in which the catheter is surrounding the needle or introducer, and at the bottom is a catheter within the needle. More information on the indwelling catheter. The flexible catheter was created to prevent what is known as losing the vein. Safety catheters have been developed that minimize risk of needle stick injury. Following successful venipuncture, the metal needle retracts into a protective sheath, preventing inadvertent needle stick injury. The basic format of the indwelling catheter consists of a metal needle, the introducer, ranging in gauge from 14 to 23 with the catheter placed over it. The catheter's length is slightly less than that of the metal needle so that several millimeters of the introducer extend beyond the catheter. To the top left, you'll see a picture of the flexible catheter, and to the bottom left, you'll see a video demonstrating how the safety catheter works. The catheter over needle design. The original design was a metal hub attached to a plastic catheter. The catheter was physically connected to the separate metal hub by a piece of plastic. The safety was questionable because the security of the hub and catheter was lacking and the catheter would come apart, migrating into the patient's veins. The modern design consists of a single unit and migration is essentially non-existent. Migration may occur if the introducer is reinserted into the catheter while it is still within the vein because of the possibility of severed pieces of the catheter.
The IV bag in different solutions.
All IV infusion solutions or fluids are packaged in plastic bags, seen here. IV fluids are available in a variety of sizes. Most commonly used include 1,000, 500, and 250 milliliters. The 1,000 milliliter or 1 liter size is common in the hospital setting when a patient is receiving long-term IV therapy. The patient usually receives 3 liters of IV fluid daily under a general anesthetic, during which time the patient must be kept hydrated throughout the surgery. 1 liter bags are commonly used. At the conclusion of the procedure, the IV infusion bag or the infusion bag represents one of the 3 items in the IV armamentarium that must be discarded. The 250 milliliter or 500 milliliter bag of IV fluids represent the most common or the most nearly identical size for the typical 1 to 4 hour dental IV moderate sedation procedure. So how do we choose an IV solution? A number of fluids are available for IV therapy, although the type of solution chosen is of potential significance in the hospitalized patient receiving prolonged IV therapy. For a short duration IV procedure, less than 1 hour to several hours duration on a relatively healthy patient, ASA 1 or 2, the choice of infusion becomes academic. Solutions available for IV administration include lactated ringers, sterile water for injection, 5% dextrose and water, sodium chloride injections. Although there are other infusion solutions available, these represent the most commonly used solutions used today. In the American Society of Anesthesiologists, ASA 1, 2, or 3 patients considered as a candidate for IV moderate sedation on an outpatient basis. There will be no contradiction to the use of any of these solutions. The question of whether a patient with insulin-dependent diabetes mellitus should receive 5% dextrose and water often arises. Will this solution elevate the patient's blood sugar level? The answer is that a 5% dextrose and water solution is not contradicted in diabetic patients. First, the contradiction of dextrose is not great enough to produce any significant changes in the blood sugar level of this patient. Secondly, the patient receiving IV moderate sedation will be requested to fast for approximately 4 hours before the planned procedure. The patient arrives at the dental office with a decreased blood sugar level, perhaps not hypoglycemic, but definitely not hyperglycemic. The addition of approximately 250 to 500 milliliters of dextrose and water will produce a slightly elevation in the blood sugar levels and a desirable effect at the time. It must be remembered that when a patient with diabetes becomes clinically hypoglycemic, treatment of choice is the administration of 50% dextrose, a solution 10 times that, which is infused during IV sedation.
So here you can see that we have a patient who has been cannulated in their right antecubital fossa, or ACF. And what we're going to do is set up a bag of fluids to be able to give this patient some IV fluid therapy. To do that, as you can see, we have all the equipment that we need. We have an IV giving set, we've got the fluids that we're going to actually administer, we have gloves for infection prevention and control, and we've got some tape to tape down the tubing itself once we've actually connected it to the cannula. The first thing we need is to do our standard checks. So if we have a look at the giving set, we need to look for package integrity, just make sure that it hasn't been opened previously in any way at all prior to us using it. We're then going to have a quick look at the expiry date. So you can see two dates on here. You have the manufacturing date, which is February 2015, and the expiry date of February 2017. So we'll check that that is in date at the time that we're actually going to administer it. We're then going to have a look at the tubing itself to check that it's intact, and once we open the pack itself, we can have a closer inspection, and we can also check that the flow control operates smoothly and will be appropriate for the patient. We also need to have a look and just see that the caps are on the ends where they should be, one on the cannula and one on the other end, ready to attach onto the cannula itself. We then do similar checks for the IV fluids themselves, but we include a few other things. So firstly, we're going to check that it's definitely the right kind of fluid that we want to administer. So we've got sodium chloride, 0.9%, which is what we want to administer to this patient. We'll also have a look for expiry dates as well. Now you can see there's a batch number and an expiry date on this itself, so 08/2019, so we're well within date at the time that we're recording this. We'll have a look at the fluid itself and just check that there's a clarity to the fluid. There's no particulates floating around in it, doesn't appear to be anything out of the ordinary there, and your packaging, just check that there's no holes in it, etc. as well. We're also going to check that we've got the covers present on the administration port, just so there's been no tampering prior to us actually using the fluid itself. So we're now going to think about connecting the giving set up to the bottle of fluids and then up to the patient. So the first thing we need to do is on the giving set itself, have a look at the flow control and just check that it is actually closed. So we're going to scroll it all the way down to the bottom so we've got a closed flow control. We're also going to check that it's appropriately positioned. You want it a nice distance away from the chamber at the top where you're going to count the drop rate. So we've moved that so that we've got a nice distance between the two. We're then going to remove the protective covers from the fluid bag and from the end of the giving set. Now it's important to be careful at this point as we now have active sharps in play. We're going to insert the cannula into the port with a twisting and pushing motion. And we should start to see fluid come down into the chamber itself. Now if we squeeze the chamber, you will see fluid rush into the chamber, and we should fill that up until it's around about half full. That will allow us to be aware of the drop rate, as we can see the drips come down as the fluid moves through the chamber once the tap itself is open. The next step is to slowly open the fluid line. And we can see the drips start to go into the chamber and the fluid moves slowly down the tubing itself. We want to get rid of all of the air bubbles, and the slower that we do this, the less air bubbles are going to form within the tubing. As it gets towards the end of the line, we can raise the end so that it slows the movement of fluid. And we should be able to control the fluid so that we get very, very minimal leakage as we get towards the end. And as the fluid reaches the end of the tube, we can close off the flow control to prevent any major leakage. We're then going to attach the tubing to the cannula itself. So we're going to apply pressure just proximal to the end of the cannula where it would be in the patient's vein, and we're going to remove the cap itself from the end of the cannula. This should ideally prevent any blood from leaking out of the cannula. We'll then attach the tubing and screw it gently into the end there. We can then put a safety loop in place on the patient's arm and secure that down with some tape. That should help to prevent the tubing being yanked away from the end of the cannula in the event of it being caught in transit.
In case of an emergency drug kit / the crash cart.
In of a medical emergency, we have a crash cart located here in the oral surgery clinic. In the first drawer, you have airway items. In the second drawer, you have more airway items. Then in the third drawer, you have IV fluids, things to start an IV. And then here you have PPE. And then in this drawer, you have certain medications that you would need in case of an allergic reaction, bronchospasm. And then in this drawer, you just have extra items, gloves, and things like that. And then on the side, you have your bag of mask, and you have your oxygen e-cylinder.
The AED.
AEDs are absolutely essential for procedures involving IV sedation. Sudden cardiac arrest is a commonly seen emergency, and having personnel that is trained in AED use and CPR can help increase emergency preparedness. In fact, the state of Tennessee mandates by law that offices must have an AED on the premises. Providers cannot be certain how a patient will react to local anesthesia, sedatives, or other dental materials, and medically compromised patients are at an even higher risk. Dental anxiety can also contribute to cardiac symptoms. Because of this, it is imperative that an AED is made available. Even if you practice in a state that does not mandate AEDs in offices, you can still be subjected to wrongful death lawsuits for failing to have an AED or not having staff properly trained. AEDs are used to analyze an abnormal heart rhythm and deliver an electric shock if necessary. They are very user-friendly and are normally automated with steps for the user. To use an AED, the operator should open the shirt, dry the patient's chest, and place pads on the areas indicated. Once attached, bystanders should stand clear, and the device can then analyze and advise if a shock is necessary. The machine will then continue to analyze the heart rhythm while CPR is administered until EMS services arrive.
Preparation for venipuncture.
When preparing for venipuncture, you first ask the patient to visit the restroom because it can be difficult for a patient to visit the restroom after CNS depressant drugs have been administered, even with assistance. You should position the patient in a semi-reclined to supine position as it allows for maintenance of cerebral blood flow and adequate respiration. You should check the preoperative vital signs, blood pressure, heart rate, respiratory rate, and O2 saturation. A baseline of the patient's vitals should be recorded at a prior visit. You place a blood pressure cuff on the left arm and it is left on throughout the entire procedure. If you're going to use a trigger test to evaluate recovery, you should perform a baseline trigger test. Using a Penrose drain to tie a slip knot superior to an antecubital fossa to act as a tourniquet. Ensure that it is tight enough to prevent venous drainage without obstructing arterial flow. A radial pulse should still be palpable. If veins are still not visible, you can use several methods to help with distension, such as rubbing on the skin and a warm, moist towel. Once a vein has been selected, you should cleanse the area with a defatting agent and an antibacterial agent.
Proper intravenous techniques.
The indwelling catheter technique of venipuncture. To begin, you want to be sure that a vein is selected, distended, and prepared for venipuncture. If the catheter is being placed in the dorsum of the patient's hand, you want to be sure that the patient clenches their fist, as you see in the first picture on the bottom left, and that you, as the provider, support their hand with your free hand, and you'll use your thumb of your free hand to pull the skin over the dorsum of the patient's hand over their knuckles, as you see in the first picture as well on the bottom left. This is important to account for the mobility of the veins so that they don't roll out from under the needle as you apply pressure and try to insert it. Next, you want to be sure that the needle is inserted at a 30-degree angle to the skin, lateral to the vein selected, and approximately 1 centimeter below the desired point of entry. The angle of entry is important, and it's optimal for it to be 30 degrees because angles greater than 30 degrees increase the risk that you actually puncture and place the needle through the vein, and angles less than 30 degrees are associated with increased discomfort as the needle passes through the skin. As you insert the needle through the skin and into the vein, resistance should be noted, and it should decrease after penetration of the skin. So, once the skin has been penetrated, the needle angle should be changed so that it is parallel to the skin. As you insert the needle and you enter the vein, you'll notice less resistance, as I stated, and you should see a backflow of blood into the tubing, which is actually a good sign, and it's a sign of successful venipuncture. Once the blood backflow is seen, the catheter should be advanced and held parallel to the vein. The needle, as you see in the bottom right picture, which is the introducer metal needle, should not be inserted more than a few millimeters into the lumen of the vein. If you do try to insert the needle, the entire length of the needle into the vessel, it can result in the loss of the vein through laceration or puncture of the wall of the vein, which could form a hematoma. So, as you see in the bottom right picture on the far right side, you want to be sure that you hold after the metal needle introducer is placed a few millimeters into the vein and you know there's puncture. You see the blood that is entered into the tubing to let you know that you have a successful venipuncture. You want to insert the catheter the full length into the vein, and you will withdraw the metal needle introducer. Also, it is important to note that while the full length of the plastic catheter should be inserted into the vein, it should be done so in a manner that is slow and gentle. If resistance is encountered while inserting the catheter, it should not be forcefully placed against the resistance. Also, the metal needle introducer should not be removed until the entire length of the catheter is in place into the vein. With that being said, once you have successfully placed the catheter into the vein, you can now remove the tourniquet from the patient's arm. You will place a dry gauze beneath the catheter to absorb any blood lost during the removal of the introducer needle. And you'll place a fingertip onto the skin directly above the tip of the plastic catheter within the vein. This will occlude the catheter and help to prevent any blood loss. A few other important things to note are that the tourniquet is removed following the complete insertion of the catheter to decrease venous pressure. It will be helpful to have an assistant to hold the needle end of the IV tubing while you or whoever the provider is removes the metal introducer needle from the catheter. The needle adapter of the IV tubing should be expeditiously connected to the catheter hub and the IV flow should be started. The needle adapter and catheter must be secured and held onto until it's firmly secured. Once the introducer needle is removed from the catheter, blood will flow back into the catheter, which is why it was important to place gauze below the end of the catheter as you see in the photos on the slide. The importance of removing the tourniquet before doing all of this is essential in this step when the metal introducer needle is removed and the IV is about to be connected. Because if the venous pressure is still high from the tourniquet, then more blood would ooze out through the catheter tubing and onto the patient or the floor. At this point, you would connect the needle adapter and the catheter. You start the IV drip and secure the catheter with, as we use in oral surgery, Tegaderm, which you see in the bottom right picture and as you've seen in pictures from the actual clinic.
For terminating an IV, the first step is to make sure the patient no longer needs sedation. The patient should also have no signs of emergence delirium, which is when the patient doesn't remember familiar people or places and they have bizarre behaviors such as kicking and screaming. If that does occur, allow the emergence delirium to pass. It normally takes 5 to 15 minutes. Or you can administer additional sedatives to allow them to go back to sleep, then wake up again. So when terminating an IV, first stop the infusion flow by tightening the rate control screw. This is typically a pump or gravity design, and pump is most common. Then hold the catheter or the needle in place while the surgical tape is gently removed from the patient's skin. Then place a sterile gauze over the catheter or needle entry point. Don't apply pressure yet because pressure over the metal needle will be uncomfortable for the patient and may injure the vein. And if you're using a flexible catheter, then this isn't a problem.
Next, gently remove the needle from the vein. Use a scoop technique to recap the needle immediately, so no one is pricked by the needle. Then immediately apply finger pressure to the gauze over the IV needle entry point and hold that pressure for about 3 to 5 minutes so that a hematoma doesn't form. Never place the gauze over the penetration site and have the patient bend their elbow. And the reason for that is when the IV is placed and the needle is removed and gauze is placed like that, not enough adequate pressure is applied and patients commonly get hematomas. So the correct way to do it is seen on the top right hand side and the wrong way is the bottom left. And last but not least, make sure the needles are disposed of in a sharps container and any tubing and bags are disposed of in a proper biohazard containers. Once again, place the needles in a sharps container and any tubing and bagging should be disposed of in the proper biohazard containers. Recovery. The patient should not be left unattended. Vitals should approximate the vitals recorded before sedation. If the blood pressure is too low or other signs and symptoms of sedation are present, give the patient more time in your office to recover with supplemental oxygen provided. The patient should be given extra time to recover if they're nauseous, dizzy, weak, or unable to walk without assistance. And never discharge the patient alone. They should be accompanied by another adult.
Hello, everyone. For this topic, we'll be discussing sterilization and disinfection, and what is the difference between those, and what can sterilization do for you as a practicing doctor. Sterilization may be defined as the statistically complete destruction of all microorganisms, including the most resistant bacteria and spores. Sterilization may be defined as statistically complete destruction of any microorganism. Sterilization is required because not all microorganisms are destroyed with regular disinfection or decontamination. The variables that affect sterilization are dryness of instruments being processed, temperature and humidity of the processing area, and whether or not the instruments were properly prepared and loaded for the sterilization. Now, a prominent person in the sterilization development would be Joseph Lister, also known as the father of antiseptic surgery. Joseph Lister, an English physician, was responsible with reducing the mortality rate of his patients in 1867, primarily by using a carbolic solution spray as he operated. He then used that spray in wounds and on articles and instruments that were in contact with any open wound, blood, or any surface which could be contaminated by microorganisms. Joseph Lister was a person who was criticized for rationalizing washing hands and being clean before operating in. The carbolic acid was a very powerful chemical sterilant that was known to kill airborne pathogens. Now, before we get into the topic of sterilization, it is important that we review the history of how sterilization came to be and how we developed the practices that we do now. In 3000 BC, the use of antiseptics such as pitch and tar, resin, and aromatics were used primarily by the Egyptians in a way of sterilizing and preserving. In 460 BC, Hippocrates used boiled water or wine to use as an irrigant. In 130 to 200 AD, the Greeks actually boiled their instruments before even caring for a wound or performing surgery. And we see that even early in the years, the development of sterilization wasn't necessarily the best, but we can see how people started to learn the importance of killing microorganisms in order to perform treatments and treat wounds. Now, a prominent person in the sterilization development would be Joseph Lister, also known as the father of antiseptic surgery. Joseph Lister, an English physician, was responsible with reducing the mortality rate of his patients in 1867, primarily by using a carbolic solution spray as he operated. He then used that spray in wounds and on articles and instruments that were in contact with any open wound, blood, or any surface which could be contaminated by microorganisms. Joseph Lister was a person who was criticized for rationalizing washing hands and being clean before operating in. The carbolic acid was a very powerful chemical sterilant that was known to kill airborne pathogens. Now, when you get into the difference between disinfectant and sterilization. Disinfectant is a chemical used on non-vital objects to kill surface pathogens. Sterilization, on the other hand, is a process by which an article, surface, and medium is freed of all living microorganisms, either in a vegetative or spore state. There is no one method of sterilization. So, I decided to break them into 3 categories. We have 1, the high temperature pressure sterilization method, the chemical sterilization method, and then the physical agent radiation sterilization method. Each one have their different modes of action, and different reasons why they will be used as a sterilization method, and we won't get into which ones are the most prominent and how they are categorized as a sterilizer and their method of action. There is no one method of sterilization. So, I decided to break them into 3 categories. We have 1, the high temperature pressure sterilization method, the chemical sterilization method, and then the physical agent radiation sterilization method. Each one have their different modes of action, and different reasons why they will be used as a sterilization method, and we won't get into which ones are the most prominent and how they are categorized as a sterilizer and their method of action. A few examples of physical agent and radiation sterilization will be dry heat, radiation, filtration, and moist heat sterilization. Examples of the chemical sterilization will be ethylene oxide, alcohol, halogens, gases, and surface active agents. Examples from the high temperature and pressure sterilization will be steam autoclave, ultrasonic, and sonic vibrations. Now, when using heat as a sterilization method, different organisms show different degrees of resistance or susceptibility to heat or temperature. Some organisms are more resistant, such as bacterial endospores, while vegetative cells are less resistant and are killed at lower temperatures. The 2 different types of heat sterilization we talked about earlier was 1, moist heat and dry heat. Well, moist heat is one of the most effective methods of sterilization. Moist heat kills the microorganism by coagulating their enzymes and proteins. Also, water vapor present in moist heat facilities. The penetration of heat into the material. Now, for dry heat sterilization, the method of action is protein denaturation, oxidative damage, and toxic effect of elevated level of electrolytes. So we see dry heat sterilization in 3 distinct processes: flaming, incineration, and hot air oven. For flaming, we see that commonly used on Bunsen flames, where we make the article or the instrument that we want to sterilize red hot. The types of instruments or articles we will be using would be inoculating loops, forceps, spatulas, and culture tubes. For incineration, the method is by using throwing the contaminated material in bulk into the incinerator in order to sterilize and dispose of all the articles. The types of things we'll see use this method is surgical dressings, disposable syringes, contaminated lab materials, animal carcasses, and beddings. And now for the hot air oven, we kind of seen that being used. It was actually discovered by Louis Pasteur in 1986. We kind of see this using trays and fans. An actual oven is used. The temperature is set to 160 degrees Celsius for an hour. The method is efficient and it preserves sharp edges of cutting instruments. Now, an example of a chemical sterilization would be ethylene oxide, which I think is a very efficient sterilizer. The positive characteristic of ethylene oxide is that it is highly penetrating and inflammable. Ethylene oxide gas is an effective low-temperature chemical. The temperatures reach usually 50 to 60 degrees Celsius. It takes longer than steam sterilization, typically 16 to 18 hours. It is used to sterilize items that are heat or moisture sensitive. It is a great sterilizer, but you can see as a practicing dentist, 16 to 18 hours to sterilize will not be very cost efficient and not be very beneficial for your practice, which is why ethylene oxide is not the most typical or commonly used sterilizer in dental practices. The gold standard of sterilization, steam autoclave. The method of action is sterilized materials are heating up objects for a particular temperature under a certain amount of pressure for an extended period of time. It is considered the most effective method of sterilization. Steam autoclave is the oldest, safest, and most cost-effective method. The steam reaches 121 to 148 degrees Celsius. The pressure chamber is at 15 psi, and the sterilization period is usually from 10 to 60 minutes. When steam enters the sterilization chamber under pressure, it condenses upon contact with cold items. This condensation frees heat, simultaneously heating and wetting all items in the load, thus providing heat and moisture, which is very good characteristics for a sterilizer. Now, the things we'll use, the steam autoclave on will be surgical instruments, of course, but is not well suited for those instruments that are not heat and moisture sensitive. Now, the key to proper sterilization is not just sterilizing your instruments and equipment. The key is to maintain a sterile operating room. And as we end up this topic, it is important to know that without a sterile operating room, you have not achieved complete and proper sterilization. Operating rooms are critical patient care areas where absolute care must be taken to prevent transmission of infections. Most cases of surgical site infections are due to perioperative exposure to pathogens. Since skin integrity is breached due to surgeries, it is imperative that the air, surface, and devices are pathogen-free. It is also crucial to maintain best practices in your medical field so as to minimize the pathogen load in the air circulating. Now, the best way to do this is to have UCVSs, or the ultra clean ventilation systems. These are sophisticated systems which are a combination of air filter housing and filter grids, HEPA filters, and priming, illumination, and air diffusers. That's why operating room ventilation is the most important part of maintaining a sterile operating zone. Thank you.
And now I'm going to talk about the factors influencing venipuncture sites. The first factor is condition of the superficial veins. Veins can be described as being tortuous, straight, hardened by age, scarred from overuse, sore, or inflamed. For tortuous veins, those are the ones that have numerous twists and bends in them, which can be bad and lead to ischemic attacks in the body's organs. The next factor is the relationship of the vein to other anatomic structures. When performing location selection for a venipuncture site, you must take anatomy into consideration. So for example, if you're going to use the arm, your main area of concern would be the antecubital fossa. More specifically, the medial antecubital fossa. Going through the fossa is the biceps tendon and the brachial artery. Another factor is duration of the venipuncture. If the patient's going to be on IV for more than 2 hours, then they're going to need to have as much movement as possible. Therefore, you would not want to place an IV in a vein that crosses a joint, like in the antecubital fossa. This would increase the stiffness and decrease the amount of mobility the patient would have in that arm. To allow as much free movement as possible for the patient, you would want to use the dorsum of the hand or the ventral forearm. Restrictions on the IV site location are less whenever the IV is in place for less than 2 hours. Next, we need to take into consideration the clinical status of the patient. If they have experienced an injury or trauma to a limb, or have had a disease that has seriously damaged part of the body, we do not want to select that area as a venipuncture site. If the patient has a history of phlebitis, you would want to use the largest vein possible or find another means of administration other than the IV. If a patient has recently had a surgical reconstruction, this could potentially lead to a severe deficit in the drainage of the venous system in that area, and you would not want to use that area for an IV placement. The final factor to take into consideration is the age and/or size of the patient. In neonates, we would want to use scalp veins because of their good accessibility. If there's a newborn who is seriously ill, the preferred location would be the umbilical vein if it's within the first 24 to 48 hours of life. Next, for small children, you would want to use veins in the foot because the upper limb veins will be very difficult to locate. The recommended sites for venipuncture are the dorsum of the hand, followed by the ventral forearm, then the lateral antecubital fossa, followed by the dorsal wrist, and finally with the medial antecubital fossa. The site most preferred because of how superficial the veins in the area are and the low level of risk of damaging important anatomy is the dorsum of the hand.
Case 1 was done by Dr. Joshua Bernstein, who practices out in Southern California. His focus is on cosmetic dentistry, IV sedation dentistry, as well as Invisalign. This case is an occlusal reestablishment case. The patient is a 55-year-old male who was referred by his orthodontist after being treated for his sleep disorder via jaw advancement surgery. His vitals were as follows: blood pressure 133/90 millimeters of mercury, heart rate 87 beats per minute, pulse ox 95%, and respiration rate is 12. In terms of assessment, the patient is an ASA class 1 and Mallampati class 3. The only medications that the patient took at the time of treatment was testosterone. Several indications for IV sedation were listed for the patient. Notably, post-surgical neuropathy was very extreme in his case, and he was very sensitive even to mild dental procedures. Patient was also resistant to local anesthesia and had an extensive fear of dental procedures. The treatment sequence was conducted over 5 IV sedation appointments. First being periodontal maintenance, second being preparation of uppers, third being seating of uppers, fourth being preparation of lowers, and the final treatment sequence was the seating of the lowers. This slide includes preoperative images of the patient. The first image on the left is the preoperative retracted view of the uppers and lowers. The following image is the preoperative upper arch, and the final image on the right is the preoperative lower arch image. In this slide, we will discuss the procedural protocol the patient went through each time they arrived for their sedation appointments. NPO and postoperative companion confirmed. Preoperative vitals taken using a pulse oximeter that remained for the duration of the procedure. Venipuncture with 22 gauge introducer on the right dorsal hand. IV tubing was attached to a 500 cc bag of lactated ringer solution, and 5% dextrose with adequate flow was confirmed without infiltration. 2 liters per minute of oxygen was administered from a nasal cannula, and tubing was attached to a capnograph. IV medications were titrated to effect for moderate sedation using midazolam, hydromorphone, and diphenhydramine. Articaine was used for local anesthesia. The patient tolerated the procedures well, was alert, ambulatory, and in good condition upon discharge to his companion with verbal and written post-operative instructions. The patient was advised to take a combination of ibuprofen and acetaminophen for post-op analgesia as needed every 6 hours with food. Using this protocol, this fearful hypertensive patient was able to undergo extensive dental treatment in complete comfort and relaxation. Proper occlusion was reestablished and his aesthetic requirements were exceeded. The patient was very pleased with his treatment and the final result. These images were taken after the 5th and final appointment where the seating of the lowers was achieved. In the first image on the far left, it shows the post-operative upper and lowers. The middle image shows the post-operative upper arch, and the last image on the far right shows the post-operative lower arch. Case 2. A 53-year-old Caucasian male presents to the clinic. He has a social history that includes a history of methamphetamine abuse. His vitals are taken, and his blood pressure is 140/86. His pulse is 84 beats per minute, and his temperature is 97.8 degrees Fahrenheit. His oxygen saturation level is 96%. As far as his medical history, he has a history of hypertension, but however, it's controlled, and he uses 400 milligrams of labetalol per day. Because of his history of meth abuse, he is in need of full mouth extractions. The surgeon decides that this patient will need IV sedation because the patient has a history of resistance to local anesthetic, and it's an invasive procedure. Here is a preoperative image of the patient. The comprehensive treatment plan for this patient includes him receiving full mouth extractions plus an alveoloplasty. His gums will have to undergo the healing phase, and then eventually he will get complete dentures for both arches. The patient was informed that he was not supposed to drink water or any beverages or eat any food after midnight the night before the procedure. However, he didn't follow these instructions, and he had a midnight snack and also had breakfast. He did not tell the oral surgeon that he had not followed this protocol and had eaten food. Mid-procedure, the oral surgeon notices a gurgling sound. There seems to be an obstruction of airway. This is because the patient has vomited. When the presence of fluid or other foreign matter is suspected, immediate management requires sectioning of the posterior pharynx. With the removal of this material, normal breathing sound should return. If vomiting occurs during dental treatment, the airway must immediately be cleared of all dental equipment. The patient's head should be turned to the side away from the operator so that the vomitus pulls on one side of the mouth, leaving a patent airway. Suction is then applied so that the remaining vomitus may be removed. The surgeon stopped the procedure due to fear of aspiration due to the patient's non-compliance.